Ko Hurikwaka toku maonga, ko Table Bay toku moana, no Awherika ki te tonga o ku tipuna, kei te noho o ki ahuriri, ko Greg Young toko inoa. He tauhunga hinenaro hau, he kai whakahaere haora I te mātou a Maui. So I'm from Cape Town originally. I've lived in New Zealand for 33 years, and I now live in Hawke's Bay, where I am a psychiatrist and a director of the local mental health service. And I apologize if I'm a bit slow. I was on call last night and spent most of the night in the ED seeing patients. So I'm not feeling so very sharp today, but I've tried to have as much coffee as possible to get ready for this talk. Thank you for having me. Now, I think I can control the slideshow. Can I just figure out how to do that? So, Bevan, how do I? Oh, there we go. Thank you.
You should be able to. There you go. You should be able to.
Thank you. So my thank you. So my interest in assessing mental capacity started when I was working as an old age psychiatrist in Lower Hutt. I got asked a lot by my colleagues to go along and help them assess whether patients that they had in their wards had the capacity to consent to different procedures. And I thought that the best thing to do would be to write some sort of guidance so they wouldn't ask me to do that work for them all the time. As you probably all would understand, any doctor should be able to assess the capacity of their client or their patient to consent to the proposed procedure. And in fact, the doctor who proposes to do the procedure is the best person to assess their client's capacity for that, because they know the information that needs to be dealt with to give that consent. A psychiatrist wouldn't know any of that. So you know, I set out on helping other people do their own capacity assessments, and I teamed up over the years with Alison Douglas, who's a barrister from Dunedin, who's got a big interest in health and disability law and advocacy, and John Macmillan, who's a professor of bioethics. And we ultimately wrote this book, which is really just a handbook to guide people as to how to do those assessments. Now, something that I find very useful, and I've only heard in the last few months, is, let me go back, is, you know, what is this thing, mental capacity? And it is, Alex Rakeen is a barrister in the UK who does a lot of work. He's quite well known for his work on mental capacity. And he described mental capacity as an idea that we have, an idea that we use, like a tool really, that has medical, legal and social elements. And we use that tool to do a particular job. So we may not always use that tool. We may get to a point in the future we don't use that tool anymore. I'm not, I want to make it quite clear, I'm not wedded to the idea of mental capacity being something we always have to work with, but we are using it at the moment. And so my goal in doing this sort of work of talking about how to assess mental capacity is to try and make sure people use the tool as well as possible and as consistently as possible. So what's the purpose of the tool? And I think that the first thing is to try and look after people's rights to make decisions despite difficulty they may have. So actually, often one should be doing the assessment and saying the person does have the capacity to make a particular decision. And I'm very pleased I'm talking after the supported decision making, because that I think is the more important context, and this sits within that context. So this is where, you know, you've reached the end of trying to do that and you still are concerned. The next aspect of it, I think, is that we're trying to address people's rights to be protected from the risk of a bad outcome from a decision they would not have made if that had all their cognitive abilities. So there's almost the opposite view, I think I need to say, from the disability sector. I've got a disclaimer here. I have a daughter with a disability, and she's in her 20s and she's at university, and I often talk to her about my my thoughts about these things, and she helps me to sort of maybe revise my perspective somewhat. So with a person with a disability who's developing their decision-making ability. It's the protective imperative is probably less important. In somebody who's losing their abilities, the protective element may become more important. It's a sort of subtle process of weighing up what you're trying to achieve. But the idea is you'd be trying to protect somebody from the risk of an adverse outcome if they would always have, the value or the will, as was described earlier, is strongly in conflict with the preference that's expressed that seems to be something that doesn't fit with any aspect of their will, and where their decisional community, a person called Wayne Martin, who's works in the UK, talks about people's decision occurring in a decisional community which supports them to make the decision. It's there are other ways of putting it, but where the decisional community is concerned as well. And the third point is to protect other people. So sometimes it's not the person whose decision. So where the person's decision only affects them, that's straightforward. But where their decision may affect other people, then the presumption that they have the capacity may need to be questioned a bit earlier. So, my daughter disagreed with this when I put it to her, but I suggested that if you had somebody who was perhaps flying a commercial aircraft with 100 passengers or something, you might not. You might reach a point where you say, I want to know that you can do this job. I'm not going to be happy to presume it. And so, for example, if they have cognitive impairment, you might want them to prove they can do the job. The interesting thing is the End of Life Choice Act 2019 has the capacity test, but the presumption is the other way around. The person who wants to end their life has to prove they have the capacity. In every other situation, it is incumbent on other people to show they don't. But in that act, for obvious reasons, that's back to the second point. One of the areas I do some work in is medico-legal work. So my clinical job is as a forensic psychiatrist. And the civil part of that is where lawyers come along and say this person is a trustee, for argument's sake, and there's, millions of dollars that are being handled by this trust, and they have dementia. And I've talked to lawyers about, is there any sort of supported framework the person can work in? But I've been told quite adamantly that's not the place for it, because they have to, as a trustee, make their own decisions. That's how the trust operates, that each trustee has an independent decision-making contribution to make. And then it becomes very, very dangerous legally for everybody, because if the person is making decisions that later get challenged by other people who feel they've lost out financially through bad decisions, you really have to be able to show that you thought it was appropriate for the person to carry on as a trustee. So, that's one example where the weight of evidence changes a bit. And it's really an argument for being able to have a good system of doing the assessment, which is fair on everybody, transparent, and that the courts accept. The history of this, I think, is quite interesting. So back in 1914, there was a case of a lady whose name was Mary Schlöndorff. That's a picture of Mary. She'd been in the San Francisco earthquake, I think, of 1906, and I think she got post-traumatic stress disorder or something like that. Anyway, she had symptoms, abdominal symptoms, and she traveled to New York, and she signed into a hospital. She didn't want an operation, but at some point, without her consent or without her proper consent, an operation was done, and she took the hospital to court. And Judge Benjamin Cardozo reprimanded the hospital, saying that every human being of adult years and sound mind has a right to determine what shall be done with his own body, or her own body in that case. So that's, 1914, that was a principle that's established. But of course, sound mind is what we're talking about now. That wasn't particularly defined then. In 1955, the next case, I've looked at this quite carefully. In 1955, the next case was of a chap called Martin Salgo, who had a procedure that went badly wrong. It had a very small chance of going badly wrong, but it went badly wrong. And the point, and I think the office of the HDC would understand this well, it doesn't, the point about this case was it doesn't matter really what the overall risk is for the population. What matters is what concerns the patient. So in this particular case, he didn't want to be doing anything that might result in paralysis, and he ended up being paralyzed. For him, that was, even though it was a small chance, that was the biggest thing that would bother him, and it wasn't explained. So so the standard disclosure there was, you've got to think about what the person needs to know to make the decision, not just what you think everybody might want to know. And various aspects of capacity were what informed consent needs to look like, and what capacity for informed consent needs to look like were traversed in that case in 1955. And in 1961, was published in 1962 in the American Journal of Psychiatry, two psychiatrists, Mieser and Reingold, presented an argument. Now, this came from the fact that people were leaving institutional care, going into the community, and the public was saying, well, you've been committed, so you must be incompetent in decisions. You can't, buy a taxi and drive a taxi as a job, or you can't get married, or you can't buy a house. So the people were being deprived of the right to do normal things because they had a history of being in these psychiatric institutions. And these two psychiatrists argued against that and said, look, each decision needs its own test. They're different. And so that whilst they may have incapacity for one kind of decision, they may have perfectly good capacity for other decisions. The thrust of the argument was that the fact that you've had a psychiatric illness and you were under committal and in an asylum for a long time doesn't mean you can't make any decisions at all. And which is obvious now, but that was a new thing then. And there are listed some of the decisions that they talked about in their paper. In 1981, Friedman was trying to grapple with, what is it that we're assessing? What is capacity that we're actually looking? And he was comparing doctors and lawyers, and it turns out the lawyers had a better sense of it. Doctors would tend to say, if you function in society, then you can make decisions. And we still see this now, but it's more done on the presumption of capacity. If you're doing okay, then you must be okay, which unfortunately fails to protect people when things go wrong. But lawyers are much more inclined to talk in detail about the issue and then discover from that whether the person was, to their minds, able or not able to make decisions about that. So a reasonable results test was one. If you make a decision, does it produce the result that we would consider reasonable? That's not a good test. Can you express a choice or decision? Well, that's fine, but you might just say the same thing over and over again, so that's got some limitations. Rational reasons, and so some people would say you've got to be able to explain why you want to do this, but not everybody operates in a way that we would say is rational, but if that's the way they operate, then that's the way they operate. Ability to understand information generically or specific information about the decision. So what I'm showing here is a sort of refinement of the process gradually over time of what we need to assess. And then we came up with our Protection of Personal and Property Rights Act, which was considered quite a novel act, quite a innovative act at the time, 1988. And what it requires is able to understand the nature of a decision, foresee the consequences of a decision or of not making a decision, and to communicate the decision. And it said that just because the decision's unwise or doesn't display the ordinary cautions, or I can't remember the wording, that doesn't mean it's incompetent. And just because the patient's under the Mental Health Act, that doesn't mean it's incompetent. So that's in the law. That was and considered quite a progressive law at the time. What started to change was, as in the 1990s, was the recognition that with the aging population, it wasn't so much about people leaving psychiatric or long care institutions, but it was starting to become about aged care and about dementia, the rising incidence of dementia. And so Lowe's article in Law, Medicine and Healthcare was focusing on how, what are the parameters of assessing decision-making capacity in a group of people where things may be changing, and cognition may be the thing that's changing the most. And these are some of the things that he felt needed to be considered. I mean, a lot has happened since then, so I won't go into detail. But it's interesting that he talked about patient autonomy back then, which is this idea of preferences and wills versus duty of care or best interests. I mean, even then they were grappling with that as being something that you need to think about carefully. Sliding scale of risk, the worse the outcome of one kind of decision versus another, does that factor in what you expect? And the differentiation of legal and clinical standards. So that's important when doctors are asked to do assessments by lawyers. Methods of making decisions for incapacitated patients, practical considerations to support patients. In 1994, there was quite a famous case in the UK called Re-C. Now, I can't do a show of hands to ask if people have heard of Re-C, but I'll quickly tell you about Re-C, and I apologize if you know this case very well. So C was a 68-year-old man from the Caribbean, Jamaica. I think he'd moved to the UK years before. He'd got involved and he'd become unwell with schizophrenia, and he had assaulted a partner, ended up in long-term care, a bit like a special patient. It was a bad situation, but he was pretty settled in his long-term care. He was in a halfway house, I think they called it, or a parole house. And so he wasn't particularly considered, danger to anybody else and like that. He was on treatment. He had a psychiatrist who knew him well. And then in this sort of situation, this legal situation, he developed an ulcer. He tripped in the shower, hurt his foot, neglected it. He had smoked for a long time, so he had bad blood vessels, and he developed a gangrenous ulcer, which needed amputation. And a very experienced surgeon said to him, look, if you don't have this leg amputated, you will have an 85% chance of dying. You've got to have it done. His psychiatrist was very concerned, and she talked to him about it a lot. And he said he refused. He said, I'd rather die with 2 feet on than live with only one. So this vascular surgeon said, look, he wouldn't operate unless the patient agreed, and he would only consider somebody incompetent if they were unconscious. They basically couldn't speak or say anything serious. So he set the bar at such a level that there was no capacity assessment. Really, everybody would agree that somebody who's not conscious can't be considered to have capacity. The patient's own psychiatrist felt that she knew him, and she was aware of his complex delusional system, which was something along the lines that he thought he was a famous doctor. He'd never lost a patient, and he could cure all conditions. That people were trying to harm him. He had a variety of delusions. They were kind of moving. They didn't necessarily stay fixed, and he could be persuaded that things weren't the case. But she thought he didn't have capacity, and they got somebody called Nigel Eastman, who's a psychiatrist, to do a capacity assessment as an independent authority. The Eastman test was, could he take in the information? Would he believe the information he heard? And could he weigh it all up and consider the risks and benefits and come to a decision? And the judge decided that he had the capacity to make the decision. And the legal principles are laid out there. I don't think I've got time to go through them in detail. The interesting thing about this case, it's a fascinating thing that happened, because I presented this case at a conference about 2 weeks ago, as a very old case, and we had discussion of geriatricians, very, very skilled people in the audience, and they pointed out, one pointed out, her family was from the Caribbean. She trained in the UK and she works in Australia, and she said, well, this sort of sounds like, his point of view sounds like people in her family would say. And then somebody else said to me, well, there's a thing about voodoo that if you take some people believe that if you take a part of their body, you then have tremendous power over them. And so maybe if we had a cultural lens on his, apart from saying that, he expressed his view doggedly and firmly, and that therefore he had capacity, which is probably debatable. But if you said in his culture that belief made sense, that's a strong reason for thinking he had capacity. So culture, came into that case all these years later after it was a case. The American group, the MacArthur Research Foundation, supported the development of a tool to look at specific elements of capacity, and these are the 4 they came up with. So can the person express a choice? Can they understand the information they have to understand to make the decision? Can they appreciate the significance of the information so that they know that it's, about them and the consequences that we're talking about could actually happen to them, and are they able to go through a reasoning process of some sort? And this test allows you to score each of those things to, how much you can do all of that. So it's not all or nothing. And the question is then, how much do you have to do any of these things to be able to have capacity? That's a very famous test. An interesting thing that came out of this, it was used in this particular article. Raymond was a psychiatry registrar, and she did this assessment of patients in a medical inpatient unit in some London hospitals. These patients they were acutely admitted they had some medical illness, and the question was a question about their treatment. They were just asked within the first 3 days, I think it was, to make a decision about treatment, and then she did a capacity assessment using that tool I've just shown you. And so 50 out of 159 patients did not have capacity. They were acutely ill. They were older people. They had, they weren't psychiatrically unwell. They might have had multiple things wrong with them. And 50 out of 159 did not, according to the assessment she did, have capacity. But the clinicians who were looking after those patients, the doctors and nurses, thought that 30 out of 50 did have capacity. So they correctly identified 12 out of 50 did not have capacity. The significance of that is, of course, the patients might make decisions about their care that they would not have made in other circumstances. The Mental Capacity Act of England and Wales, 2005, England and Wales, defined the four parts of what you need to be able to do, the four cognitive processes you need to be able to do to have capacity or to make decisions. Understand the situation, the problem, retain that information, use or weigh the information as part of a reasoning process, and communicate the decision. Now, in New Zealand, this test has come through in the End of Life Choices Act, and it's also come through in the Substance Addiction Compulsory Assessment and Treatment Act, and it will probably come through in the new mental health bill, the proposed change to the Mental Health Act. So it is recognized as a good formulation, shall we say, of a good laying out of what you need to do to have capacity. And so we've used that in our book and our toolkit as the things we ask people to assess when assessing capacity. Why might you question somebody? So we encourage clinicians to think about when you might question somebody's capacity. So the starting point is usually that the person does have capacity, and you go through life presuming that people talking to you are able to make the decisions they propose to make. But there's situations where perhaps you should think about that more carefully. Risky decision taken against advice, changing character with respect to previous decisions. So they wouldn't normally have decided this. An abnormal state of mind through illness or dementia, where the decision has some consequence for the person or the family is concerned. That's, I think, there was research done into the rates of incapacity. So we're not saying this is a wildly common situation in healthy elderly, 2.8% in this particular assessment. And this was also a medical treatment decision. 2.8% had incapacity. So vast majority of people had capacity. If you just assume people had capacity, you'd be right most of the time. Vast majority of the time in an elderly population. And even in people with mild cognitive impairment, which is that precursor stage to dementia, you'd be right most of the time if you presume capacity. But it gets higher. And again, I'm not arguing that at this point, for example, in a learning disabled group of people where there's a high chance that they might not have a capacity or decision, that a substitute decision should be made. But perhaps if you had the correct supportive framework, you might change that. But you need to know to use it. You need to be alive to that possibility. We wrote a toolkit which was just designed to take those four elements and put them into a procedure. And the procedure we talk about is a 3-step procedure for clinicians where you gather the information, you understand what the issue is and why a decision has to be made, and you work out what the person might need for support, and you satisfy yourself that before you assess for incapacity, everything has been done to support the person making the decision. So we don't see this as a first step. We see this as something you do as almost like a last resort, really. But this is how you do it. And the middle step is the assessment, and the last step is the summarizing in your mind of where you think you've landed. I've made a slide of who should do assessments, and this is really to persuade doctors that they need to assess their patients, particularly for procedures that they propose to do. No good calling a psychiatrist if you want to do leg surgery or something. So another group I talked to quite recently was a group of lawyers. And I mean, lawyers have a difficult problem because if somebody comes along and gives them instructions, I mean, the High Court, I think the Chief Justice has actually given the view that you have to take instructions. But then the problem is, what do you do if you think the instructions are not capacitous? If the person giving the instructions doesn't have the capacity to give the instructions, I mean, how much expense do you incur on that person's behalf? Because going to court is expensive. Before you stop and think, is this really the right thing to do in this situation? So that's the tricky thing for lawyers, because they're ethically obliged to follow the instructions of their clients. They also have to act in their client's best interests. So I'm not a lawyer. I'm not going to try and answer how you decide that. When lawyers assess capacity, they're very skilled. They know the legal test. And so when lawyers write to me and say, can you tell us retrospectively whether this person had capacity to do this thing years ago? There's a family dispute about that now. I asked them to explain to me what was the decision and what's the legal test? What is the threshold that would be enough capacity to make that decision? And then I try to look for evidence one way or the other. Clinicians, we focus on the legal test because we need to understand what it is. But we also, with the patient's or the client's or the person's consent, we can access medical records. We can ask what the medical procedures are, or we can arrange for the person to have things done to improve. So if a person is very ill, I was talking to a group of lawyers last year, and they presented a case of a person who was clearly very depressed. And I said, well, I wouldn't want to do a capacity assessment until we'd address the depression. In fact, I'd be worried about the person's welfare with that level of depression. So, parking aside the whole question of the capacity to complete a relationship property dispute, are they okay? So we should be looking at it like that. We should be looking at what we do to help this person's health. It's also probably more common for doctors to talk to family members than lawyers to do so. What I've said, though, is that we do need clear instructions from lawyers. So I need to speed up a little bit, but if anybody goes for a capacity assessment with a doctor, there are two parts the doctor will need to look at. The one is the general health. Like I've said a minute ago, we want to help people if they're not well, and we need to look at that. And if the person's got a fluctuating condition, then we need to optimize their medical treatment before we settle on what their capacity is to make a decision. And the second part of the assessment is the decision-making capacity itself. We need to have instructions. We need to know stuff we don't normally know. So if it's about a will, we need to know how much money the person's got. We don't normally need to know that as doctors, but in this instance, if that's what we're asked to assess, we do. And that sometimes offends people because they question why we need to know that. Well, this is why. I'll quickly say there are problems with the capacity assessment model. Some have been referred to in the earlier talk. We don't easily factor in values, emotions, or religious faith. We don't have a way of measuring that. We can only go by what the supportive group tells us is the norm. So our opinion it doesn't come into it, shouldn't come into it. People have different appetites for and different perception of risks and benefits. So some people would stay at home and are not worried about the risks associated with that. Other people, perhaps even family members who live overseas, might have a different view. And autonomy is the autonomy of the individual, autonomy of the family. I'm not quite sure what autonomy we're always talking about. We should be thinking about. Practical measures are perhaps the obvious ones, and I don't need to tell this group what they are. And so my conclusion is that capacity assessment is based on the idea that the person's autonomy is the most important thing, and we consider the measures that we need to put in place to support autonomy when the person is no longer able to exercise it. And the assessment might actually show us some things we can do to help. But as a last resort, if we determine the person lacks capacity, we may then suggest other options like a surrogate decision of some sort. That's my talk. Thank you.
Thank you very much, Greg. Now, we've had a question come through on the chat, which just asks about the parameters for who's making these kind of decisions as a clinician. So if someone has a situation where they're concerned about someone's mental capacity, so does it include, for example, social workers, or what is the scope for who can be involved in making this kind of a decision if someone has a concern?
So it depends a little bit on the decision, but I'll go to the one that I think is the commonest and most difficult, and then we can work towards more specific examples if people have something in mind. So I think probably the worst decision you have to make as an old age psychiatrist. So I was an old age psychiatrist for 10 years before I became a forensic psychiatrist, and the worst decision is the decision that somebody has to go into care. They can't stay at home. They can't go back home. And that decision is not really a medical decision. It's the medical decision is about the cognitive disorder and whether that's reversible or what the pathway is and how bad it is, and about so that's the mental part of it. Then there's the physical risk. So often there'll be a thing like the person's got medical conditions, or had a fall, or has certain rehabilitation needs, and what the needs are to address those problems. So that's I would see a partnership between a psychogeriatrician and a geriatrician. That's the first thing. But then there's the question of the person's home situation and how they manage in that situation. If you're arguing they can't go back to it, why are you saying that? And that's an occupational therapist. And then there's the question of what the family views are, and we all, of course, want to know what the patient's views are. I'm not saying that because that's a starting point. I'm saying here they want to go home. So we work with that, but we do not want to know the family views. So where it's a cultural issue, I'm obviously not Māori, and I would want Māori advice if that was the cultural group. When we wrote our book, we had somebody help us with that. A friend of mine, Joe Baxter, who is the Dean of Medicine at Otago, assisted us with that chapter. But of course, we didn't cover other cultural groups, which we perhaps in future iterations of the book would do. So who should help in coming to the conclusion as to what to do about capacity? It's in a multidisciplinary team, plus the family, plus the person.